رجعت لكم تاني من مؤتمر النيورودياب من هنا من بوخارست في رومانيا، مؤتمر الجمعية الأوروبية لالتهاب الأعصاب السكري، ومعايا أستاذي بروفيسور بروس بيركنز. Good morning, Professor.
Good morning.
Will you please introduce yourself?
Yeah, absolutely. I'm Bruce Perkins. I'm an adult endocrinologist and clinician scientist at the University of Toronto in Canada. And I kind of focus my research around mostly type 1 diabetes and diabetes complications.
Wonderful. So, what's your most recent research in the field of diabetic neuropathy?
Yeah, so my interest in neuropathy, to be honest, is figuring out ways that we can just do a much better job of identifying who's developing neuropathy, who's at risk of developing it in the future, so that when we develop better therapies, we can apply them and help prevent neuropathy from progressing.
So, in this case, I'd first like to ask you, what is diabetic neuropathy, as you are the expert?
Sure. Yeah, so, diabetic neuropathy, it turns out there's a whole bunch of different types, but by far the most common is just a kind of general injury to all our peripheral nerves that leads to problems with sensation that begins in the toes and works up, can gradually and slowly work up the feet into the legs and even involve the hands. And the reason that it's a problem is because people, first of all, they can have pain, but secondly, they can lose protective sensation, meaning they don't feel the ground or little injuries as well. That can lead to breaks in the skin, that can lead to little ulcers, infections, and they can be completely unaware that this is happening until it's too late. So an ulcer expands, infection can get into the tissue of the foot or into the blood, and then people might need amputations.
So basically, you're talking about the nightmare.
It's sort of, actually, you know what, it's the thing that people with diabetes fear the most.
Yes,
it is the nightmare.
Definitely.
They fear it, we fear it even more than death itself. And I can understand that. But it's all kind of fairly simple. If someone's developing, like as long as we're doing some tests in the clinic, and they can be simple, just to see whether someone is aware of if they can feel with their feet. And if they don't, then we just start making them more aware of it. So they look at their feet every night or two, see if there are injuries. And so if there are injuries that show signs of infection, like pus or fiery redness, they call their doctor and they get an antibiotic immediately. So it's not like there's nothing you can do to prevent the late stage complications. But wouldn't it be nice if we could just prevent the problem with sensation, the protective sensation in the first place?
So here I'd like to ask you a simple, well, it's not simple. Actually, it's a very nasty question, but it's a direct question.
I'm ready.
Okay. Please don't get mad at me.
Okay, I'll try not to. If you see the camera fall and screaming, then you'll know I got angry.
Okay. Is diabetic neuropathy a one-way disease which will happen, progress, and there's nothing to do?
Yeah. So, interestingly, at this conference, I'll be debating this topic in a day or two. In my heart of hearts, I hope that when someone's developing neuropathy, that it can be reversed.
Okay.
And we know that at very early stages, but I mean, these are stages where people are not even aware of it. Like we call them preclinical. I'm not sure they're important enough. For sure they can reverse. But once someone's developing significant symptoms, I believe that there are individuals that if they can improve aspects of mostly blood sugar control, that they can improve. But so far, the data doesn't exactly show that it can.
But from our clinics, we have many cases who have actually improved.
Yeah, but improve from, give me an example. Improve from what symptom to what symptom?
Okay.
Or sign?
Okay, so let's look at it this way. If I have someone who has severe pain, can't sleep, and now can sleep, okay, I believe this is good improvement. On the other hand, if I have someone who has this terrible numbness, feeling, etc.,
Yeah.
okay, and now it's gone, okay, I believe it is some improvement.
Agreed.
And additionally, when you get people who are really, really out of control, okay, even with the small fiber neuropathy tests, okay, I do pseudoscan, you probably do corneal confocal microscopy,
Yeah,
okay,
those for sure can
okay,
improve.
these definitely improve. We have science, biophysiometry, which vibratory perception threshold, which tells us the large fiber status. EMG,
Yep.
okay, improves. Patients with, for example, diabetic amyotrophy, these definitely improve.
Yeah. Well, the reason this
Okay.
conversation's awkward is only because I'm doing this debate, which is on clinical neuropathy reversing. So, what does clinical neuropathy mean? It doesn't mean having an abnormal nerve conduction study. Like those who may know out there, nerve conduction studies are a way to measure nerve function, so it can be abnormal, but someone may not even know that it's abnormal. They feel fine. To me, clinical means they have to have some problem. They've got pain or they've got numbness and they realize they can't feel the ground. But to me, even if they don't realize it, if I test their feet and they don't feel, for example, light touch, and then later they do feel light touch, I think that's really important. That is a sign of clinical reversal. And I agree with you. I do have some patients where I've seen it happen. I've tested them, they don't feel anything. We've worked on their diabetes, and like a few years later, we test again and they seem to feel normally. But in our research studies, it doesn't seem like that's a very common event.
Let me tell you something, Frank, from my personal experience.
Yeah.
If the diabetologist is really minded with diabetic neuropathy, they tend to get better results. What did you say about that?
Say it again. If the clinician
is really minded,
like really aware of,
yeah, he's really aware, he's interested in it, okay, these tend to get the best results.
Oh, for sure. Because the messages aren't that complicated. If you could have a doctor who hasn't tested your feet, and you may never know that you have like some impairment or aren't able to feel, let's say, the shoes, or if you're getting an injury. And then you could have a doctor who does test your feet and says, oh, I'm just a little worried that you don't have perfect sensation. I want you to keep a closer eye. Like very simple things can help prevent really bad complications like ulcers and infections. So that for sure. And then secondly, I feel that if you've identified that someone has, like, let's say, early neuropathy
is wonderful.
Then you have more motivation to do more stuff. Like, let's say it's someone who has type 2 diabetes who maybe their control's not bad and they're on this diet and exercise and this medication, but now you're more likely, because you're aware of this new early complication, to do more and get them for sure to target. If it's when we know about early complications, it serves as a motivation to help people get even better control than they otherwise would.
What about the DCCT?
Yeah, so
the EDIC. You were an investigator in this.
Yeah, and I'm the vice chair of EDIC now.
So, okay, first of all, what's DCCT EDIC? What is it in the first place?
So DCCT, it stands for Diabetes Control and Complications Trial, DCCT. And it was a trial that was started in the 1980s, designed to test in people with type 1 diabetes.
You were 2 years old at the time, yes.
Exactly. I wasn't I was born. In fact, when I was diagnosed with diabetes, I could have been in the DCCT, but I somehow wasn't. Anyway, now I'm involved in it. It would have been complicated if I was a participant, I guess. What that study did is it randomly assigned people to have typical diabetes control, which in the 80s was like, just take some insulin, like a shot or two a day, and just make sure you don't have symptoms of a high sugar, like always peeing and thirsty all the time, compared to trying to get blood sugar levels to as near normal as possible by using multiple injections of insulin or an insulin pump. And in that day, believe it or not, the research or clinical community, people didn't know whether it actually mattered whether you had better blood sugar control. They just thought if you're going to develop blindness or kidney failure or nerve disease, you're going to get it regardless of blood sugars. But this proved without any doubt that having better control has a huge effect on reducing all those complications, eye, kidney, and nerve. And now we know about heart. And now we know about even new complications that are just emerging. And they're related to the like overweight
What do you mean
and
new
emerging complications, for
Yes. How
example.
can something be new in this
Yeah,
subject?
it means that we hadn't recognized that it happens in people with type 1. So, for example, liver disease, so fatty liver and its consequences are actually quite common in type 1 diabetes. We're now learning from the DCCT and its follow-up, because that trial ran in the 80s into the early 90s, but then everyone agreed to have long-term follow-up. Every 5 years, we've been renewing this grant, and we've been following these people for over 40 years. And the vast majority are still in follow-up with us. It's unbelievable. We've also learned that there's more sleep apnea, difficulty or disordered sleep. So these are what we would call new complications, and the other are the what we call age-related. So, for example, now as people enter older age, like into their 60s, there's this interaction between having diabetes and the loss of cognition or thinking, or what we call
Alzheimer's.
dementia. Exactly. So these look like. So what we're trying to better understand is how big is the problem with having dementia, Alzheimer's-like disease in type 1 diabetes, and how can we predict who's going to get it, and what can we do to prevent it?
So, because I remember 90s when I was a medical student, I was told at the time that if you have diabetes, you will get all of these complications, whatever you do. It's a matter of time. And diabetes is a sentence for these complications. Okay, these will happen. And I remember that our target at the time was to keep people's blood sugars between 200 and 350 milligrams per deciliter. Okay, which is like, if someone says this now, he'll be a criminal who should be shot. And
No, that's
Okay.
not. If you live with diabetes out there and your sugars are running in that range, seek help, because even if you feel well, that's going to lead to complications. Now, listen, occasionally you'll have, but as long as it's not the pattern
It's
day
not the
by
norm.
day. Yeah, exactly. That is important. So what we've learned from DCCT edict is those people who had what we call intensive insulin therapy and better blood sugar control, they have the same life expectancy as the general population. So in other words, yes, diabetes and above target blood sugar control over the long term is the leading cause for blindness, kidney failure, neuropathy, amputations, heart disease. But having diabetes and target blood sugar control is the leading cause of nothing.
Exactly.
And that's an important message, because, you know, now someone diagnosed with type 1 diabetes or type 2 diabetes, we have so much to help people, as long as they're committed to just accepting the help and to figure out how to reach these targets and know what the target should be and just do it. They're set up for a lifetime like a life if they never had diabetes.
Exactly.
Yes, there's some extra work and whatever, but they can expect to lead a healthy life free of complications. I think it's an amazing, hopeful message.
Yes.
Yeah.
Yes, it definitely is. Is there anything else you'd like to tell us about your work in the field of neuropathy? I know you've done a lot.
Yeah.
Okay.
You know, I'm realizing a lot has to do with like new methods and to try and determine who's going to get significant nerve injury. But we have to figure out as a community what we're actually going to be using before I talk about it with the public, because it's a lot of painful details. I will say, though, through that DCCT study that we've been following people, like 1,400 people for more than 40 years, we've learned a bunch of weird things, you know, like getting nerve pain is pretty common. It's more common in women. And it can happen even when people have very, very early stages of neuropathy. So, a key thing that we're trying to do is find better treatments for nerve pain. And as it turns out, nerve pain is a little tricky because before you said someone could have pain and then it goes away, sometimes that can be a sign that the nerves have gotten worse.
Yes.
Because they're not even
Yes.
functioning to tell us about pain.
Okay.
So that wouldn't be a great example of like reversal of neuropathy, but
Of
it could be.
course. Okay.
But the treatment, we do have treatments and they can really work. So you got to be aware if you're struggling with nerve pain, like, sharp pains in the feet, burning pain, that waking you up at night, impairing your sleep. There are treatments that can really take that edge off, not get rid of it completely, but take the edge off. So you got to talk to your doctor about these. But there's now been a big interest in the research community to develop new types of treatments for this. And there's a whole bunch of them that are in clinical trials now. It's actually, in my mind, very promising for the person who's got nerve disease with pain. Now, not everyone has pain. Sometimes they're just losing that protective sensation. And for them, the main thing is control their diabetes, follow the advice for blood sugar control, etc. Blood pressure, cholesterol. Do not pick up the habit of smoking. That is bad for sure, for not just for nerves, and not just for diabetes, but for everything. And then finally, to be aware that their feet aren't feeling little injuries and keeping a good eye on their feet, good foot health. But that's it. Those are all very manageable things. There's no reason to be depressed if you're in that situation. There's a lot that can be done.
I have a question here, which I'm asked so many times by lots of people on the internet. Are cholesterol drugs bad
For nerves?
for humans?
Cholesterol drugs, like it would be...
Statins.
Yeah, it would be such a terrible thing for me not to speak extremely positively about them. There's, any medication that's used very commonly, there's a lot of bad news about them on the internet, people with bad experiences, because so many people have been on them. But on average, those drugs are like a miracle drug. If, for example, if you have diabetes, even if you have normal cholesterol, because most people, for example, or a lot of people with diabetes have normal cholesterol, but if you make them super normal, like lower, it helps decrease the huge plaque buildup that can happen in our arteries and reduce the risk of heart attacks and strokes by like 60%. Like the hazard or the risk is reduced that much. So we have such great evidence that they do that. It would be crazy for us as physicians or people out there not to encourage others with diabetes to be on these medications, and even those without diabetes who are at higher risk of heart attacks and strokes. So it's the one kind of, there's a few things that I'm quite pushy about, but that would be one of them that I'm very pushy and insistent with people, because if you live with diabetes and you've made the decision that you'd like to get through life without any complications, by starting a statin medication, certainly by the age of 40, in many people even at the age of 30, that is one amazing way to help you reach your goal of getting through life without complications, for sure.
Okay. What about the effect of statins on nerves, kidneys, eyes?
Yeah, so there's been this worry that maybe statins could somehow worsen nerve function, but...
Okay. Let's be, there is statin-induced neuropathy.
Yep.
I have seen in my career one patient.
Right, like that's the idea. That it theoretically can happen, but for the vast majority it doesn't. So it would be terrible for someone in this situation not to take it.
We're talking about a prevalence of what, 1 in a million, probably, something like that, 1 in 2 million.
Yeah, maybe less. Yeah.
Maybe even less. Okay, we're talking about something which basically doesn't happen. So one case is nothing. Is it true that nerves need the cholesterol in the blood to build their walls, or do the nerves make their own cholesterol?
Yeah, so I mean, nerves do, or some of our nerves have these like protective sheaths around them that do depend on cholesterol. But trust me, it's not like you can lower cholesterol blood levels low enough so that they're not going to have to be able to have their protective sheath. Like, for example, we have some hormones like testosterone that use cholesterol to be made. They're made out of cholesterol. But even if you lower cholesterol to like essentially undetectable levels, we still make enough testosterone. I believe it's the same with our nerve function. Yeah.
Anyway, so today we talked about what we talked about.
I don't know.
First?
We just went on, and it was really fun actually. We talked about, you asked me about neuropathy.
Yes.
What is it?
Yes. So you're talking about the predictive models, which will be a very good idea because I can tell someone, listen, you can get, you have a high probability of getting neuropathy. Please take care of this. Okay. Have better control of your blood sugars, blood pressure, cholesterols, etc. And this should protect. Do not smoke, definitely. Okay. Then we talk about you mentioned the newer identified complications of diabetes.
That's right.
Okay, and these include the fatty liver. These include obstructive sleep apnea. Okay, and
the risk of dementia.
And the risk of dementia. Yes, this is our newest hot topic. Okay, which I personally have absolutely no understanding of yet.
Yeah, well, we're starting to get a better. No one does have a perfect understanding of it yet.
Okay, then we talked about other drugs, the importance of controlling your blood pressure, controlling your cholesterol. Okay, and cholesterol drugs are not a bad thing. Please, they are not a bad thing.
They're a miraculous thing.
Okay, and would you like to say something before we end about obstructive sleep apnea and neuropathy?
Maybe not, because that's a complicated combination as well, and we don't understand a lot about that. There's a whole bunch of things that can lead to obstructive sleep apnea that may separately lead to neuropathy, but there may be a direct connection, because when we have sleep apnea, we go through parts of the night where we really decrease our oxygenation.
Yes.
And this dipping in oxygen may harm certain, like it leads to a number of problems that could theoretically affect nerves. So I think it's important to identify sleep apnea. I don't know how to do it properly, because if there's such risk, for example, in people with diabetes, getting everyone tested is complicated. There are some simple questions we can ask, or questionnaires.
The questionnaires,
that help.
Yes. Okay, and of course the golden standard, the sleep study.
Yep. And actually, some companies have developed.
There are quite a few devices.
Yeah, they're not bad actually.
I tried one. You just stick it here on your chin, and next day it gives you a really good report, AI generated. Okay, there's one which comes with like a watch-like device and something on the thing. Okay.
Yeah, it's using what we call tonometry. It's looking at kind of like how the arteries are changing and functioning, and it gives an indication of sleep apnea.
We did something back on my group. We managed to put a protocol which measures ectopic fat in the tongue and the palate, the oropharynx.
Yeah.
Okay, and that tells you if we do have ectopic fat or we don't. Okay, and
I see.
If you have ectopic fat there, you have a high probability. If you have a large tongue, if you have this, you have a high probability. And the good part about ectopic fat is we're using the newer GLP-1, the injections for losing weight, the blood sugar injections which are used for losing weight.
And do those specifically lower fat around the tongue and in the throat?
For some very absurd reason, yes, they do. And we have proof about this, like the SURMOUNT OSA trial, which came out and showed a 50% improvement in apnea-hypopnea index, which is the number of times and the duration where you lose...
stop breathing, basically.
Stop breathing. Okay, it showed a 50% whether you're using the machine, the CPAP, yes or no. In both cases, it dropped it by 50%. And the point here was because because I actually have a problem getting people having sleep studies. I send them doing these MRIs.
I see. I
It's
see.
easier and cheaper, believe it or not.
Yeah. It's a little complicated because, sleep apnea is associated with overweight and obesity, but there are a lot of people who have sleep apnea without overweight and obesity. Um, so I wonder whether you're able to pick up, like with MRI, looking for the fat deposits, just one type of sleep apnea.
It's the commonest with type 2
But
diabetes.
but you're right that
Okay,
it's probably the dominant. Most people will.
with type 2 diabetes, not with type 1, not generally with type 1, because right now, okay, I'll tell you
Well,
what, why don't we talk about NASH and overweight with type 1 diabetes? Because this
sure.
is, okay, so thank you, Professor, for today. Okay, and we shall continue in our next episode.